Today we will start with remaining water soluble vitamins. Out of that, vitamin B complex and non-vitamin vitamins, water soluble vitamin. So first, pyridoxine. Pyridoxine, it has three vitamins: pyridoxine itself, pyridoxal and pyridoxamine. The active form of vitamin B6 is PLP, pyridoxal phosphate, and it is closely associated with metabolism of amino acid, and almost maximum of the amino acid metabolism, PLP is directly or indirectly involved. So this is called vitamin of amino acid metabolism or protein metabolism. So synthesis, certainly certain specialized products like serotonin, histamine and niacin, another vitamin, and its nucleotide NAD and NADH is synthesized from indirectly vitamin B6 also. In vitamin B6 deficiency there is deficient synthesis of NAD and NADH. PLP participates in reactions like transamination, decarboxylation, deamination, transsulfuration, condensation, etc. These are the all reactions of amino acid metabolism. So this is the structure of vitamin pyridoxine. It has a pyridine ring, and its vitamins depends on the functional group attached to the fourth carbon of pyridine ring. When it is alcohol group, it is pyridoxine. When it is amine group, it is pyridoxamine, and when it is aldehyde, it is pyridoxal. Okay. Now this carbon is phosphorylated, esterified with phosphate, and the molecule become pyridoxal phosphate. This is the active form of vitamin B6. Is abundantly present in egg yolk, fish, milk, meat, and vegetable source, sweet corn, cabbage, roots and tubers are good vegetable sources. RDA is adult 1.6 to 2 milligram per day. Children will get less, and pregnancy and lactation will have to get more, say 2.5 milligram. These are the reactions, biochemical reactions, which require this PLP, pyridoxal phosphate. These are transamination, decarboxylation, then deamination, heme synthesis, tryptophan metabolism, glycine metabolism, methionine. These all are amino acids only. Then in glycogen metabolism also it is required. Sphingolipid synthesis, coenzyme A synthesis, pantothenic acid. That synthesis of coenzyme A from pantothenic acid, that also require vitamin B6. So one by one we will see transamination reaction. What is transamination reaction and what is deamination reaction? Transamination reaction is transfer of amino group to some molecule to the another molecule, from transfer of amino group from one molecule to the other molecule. Okay, this is transamination. Deamination means removal of the amino group. It will remove and it will throw out the amino group. Okay, so here what happens in transamination? One amino acid, from one amino acid, the amino group of group will be transferred to a keto acid. So the new keto acid, where amino group is transferred, will become a new amino acid. Okay, and the amino acid, from where the amino group is removed, will become a new keto acid. Understood? So alanine is the amino acid. Amino group is removed from the alanine, and it has become a keto acid This is pyruvate. Alanine has converted into pyruvate, and the alpha-ketoglutarate, which is a keto acid, has become a new amino acid, glutamic acid. Understood now? No confusion. There should not be any confusion when you go for protein metabolism. The same reaction you will have. And in the examination, you will get right short note on amino transamination. Definitely. Transamination, deamination, transsulfuration, these they give, not transsulfuration, they don't give much, but transamination, deamination, very frequently they used to give. You have to write this only. Okay? You have to explain why the new amino acid is becoming keto acid, and at least mention one reaction. So here I have mentioned two important reactions. Alanine and alpha-ketoglutarate with the help of PLP. The enzyme responsible is alanine transaminase. Substrate is alanine. Transamination is caused by the transaminase. That's why it is specified as alanine transaminase. This transaminase acts on alanine. Okay, so pyruvate is formed from alanine, and glutamic acid is formed as new amino acid. And this is also called ALT. Okay, alanine transaminase is also called ALT, and it is this enzyme is this reaction mainly occurs in liver. So in liver function we see this enzyme, whether it is increased or decreased. Now another is aspartate, and amino group from the aspartate is transferred to alpha-ketoglutarate, which is a keto acid, and the alpha-ketoglutarate becomes a new amino acid, glutamic acid, and aspartate becomes a new keto acid, that is oxaloacetate. And then this oxaloacetate enters in the TCA cycle to give energy for further metabolism. Now in this reaction, what is the function of PLP? Amino group is first received by the pyridoxal phosphate. Okay, it will take the amino group from the alanine or aspartate or other molecule. It will receive it and will become pyridoxamine phosphate. Then it will transfer to the keto acid. So amino group is transferred via PLP. First the group is transferred to the PLP, then further transfer occurs to the molecule of interest where it should be transferred. Now here are decarboxylation reaction. Decarboxylation of amino acid, they form biogenic amines like serotonin, which is very important, then epinephrine, norepinephrine, gamma amino butyric acid, these are all neurotransmitters, and histamine. Histamine is responsible for allergic reaction, and it is mainly responsible for the allergic reaction. Here is a deamination. The ammonia is removed. Serine is a amino acid, threonine is an amino acid. So in metabolism of these amino acids, hydroxyl containing amino acid, the amino group is removed as ammonia, and the this keto acid is formed. This is reaction occurs in metabolism of amino acid, hydroxyl containing amino acid. The enzyme responsible for this dehydratase. So when you are asked what are the biochemical function of pyridoxine, you mention the name and give one reaction. Detailed reaction you need not give, just like that, what we have written in the slide, like that only you give, that will give you full mark. Now this is a condensation reaction. Here the succinyl-CoA is condensed with glycine with the help of delta libulinic acid synthase, and the delta libulinic acid is synthesized. Okay. Now it is the delta amino libulinic acid is required for hemoglobin synthesis. Okay. Now if there is PLP is deficient, then the patient will develop anemia, because there will be no hemoglobin synthesis. This is a condensation reaction. Tryptophan metabolism, it is mainly hydroxylation reaction. Here, tryptophan is hydroxylated in 3-hydroxycanoadenine reaction. From there, the 3-hydroxyanthranilate is synthesized, and following some reaction, the niacin is synthesized. So, responsible enzyme is kynureninase. Kynurenin is the responsible enzyme which convert 3-hydroxycanoadenine to 3-hydroxyanthranilate. Now, deficiency of PLP will stop the reaction here, and there will be increase of 3-hydroxycanoadenine. Okay, and it will be converted as xanthurinate and will be excreted in urine. So we are interested where the PLP is catalyzing the reaction. This is the enzyme where PLP dependent, which is PLP dependent. So when PLP is deficient, there will be hampering of synthesis of niacin from tryptophan. As I told in last class, 60 milligram tryptophan is required for synthesis of 1 milligram niacin. Here, so deficiency of kynurenin is there. So 3-hydroxycanoadenine, it is converted into xanthurenic acid, and that is excreted in the urine. So in case of PLP deficiency, we estimate whether urine contains xanthurenic acid or not. And again, about 3% of the 3-hydroxyanthranilate converted into niacin, that road also is blocked. So niacin deficiency also hampered. In methionine metabolism, this homocysteine is converted into cystathionine by the cystathionine synthase, PLP dependent enzyme. Now, if there is deficient PLP, then this homocysteine increases, and that causes homocysteinuria or homocysteinemia. Homocysteinemia means there is increased homocysteine level in blood. Homocysteinemia, increased homocysteine in blood. Homocysteinuria, is increased homocysteine level in urine. Now, it is an example of transsulfuration, okay, because there is transfer of sulfur group from cysteine to serine to cysteine, serine to homocysteine, and cystathionine is synthesized, and further cystathionine synthase synthesize this cysteine residue, cysteine amino acid from cystathionine. So there is a transfer of sulfur group from one amino acid to another amino acid. Now in glycogen metabolism, as we know, glycogen is the stored form of glucose in the muscles. When the situation arises, the glycogen undergoes glycogenolysis, and it releases glucose 1-phosphate. It is acted upon by the glycogen phosphorylase. Okay, glycogen phosphorylase, and 80% of glycogen phosphorylase is PLP dependent enzyme. It requires PLP. 80% of the PLP activity is found in the muscle. Majority of the PLP is involved in this glycogen metabolism. So here sphingolipid synthesis, this is also PLP dependent enzyme, and there is, when there is deficiency of PLP, there is synthesis of sphingolipid is reduced, and that results in peripheral neuritis. Coenzyme asynthesis, that also require PLP, pyridoxal phosphate. Now, deficiency manifestation, pyridoxine deficiency is associated with neurological symptoms like depression, irritability, nervousness, mental confusion. These are because of the deficient synthesis of neurotransmitter serotonin. Okay. Now, convulsion, peripheral neuropathy are observed in severe deficiency. This is because of the gamma-amino butyric acid synthesis. There is deficient gamma-amino butyric synthesis. This is a inhibitory neurotransmitter. So, deficiency of this neurotransmitter will cause excitation in the body. That excitation is the result of convulsion. Now, that is the result expressed as convulsion. Then these are the neurotransmitters which will be deficient, and accordingly these symptoms will be produced. Demyelination of the neuron is observed, and when there is demyelination, the patient will complain of burning sensation of the limb. Peripheral neuritis will be there. Then PLP synthesis, because of the it is involved in hemoglobin synthesis also, so there will be less hemoglobin. Hypochromic microcytic type of anemia will be there. This is due to the decrease in heme production. Vitamin B6 deficiency causes are other causes: isoniazide, hormone on oral contraceptive, then penicillamine, then newborn infant fed with formula which contains less vitamin B6, alcoholics due to malnutrition, and again ethanol is converted to acetaldehyde, which inactivate the PLP by hydrolysis of phosphate from PLP. So these things, this is an anti-tuberculosis drug. So all these things, they will inhibit the PLP and will cause peripheral neuritis and other PLP deficiency, other problems of deficiency of PLP. Now, in case of isoniazide, it combines with PLP to form hydrazone. This inhibit the PLP dependent enzyme. This enzyme, the isoniazide induce inhibition of PLP dependent enzyme. It responds to vitamin B6. So when we give vitamin B6, his problem of this inhibition by isoniazide, it disappears. So when we give anti-tubercular drug to the patient, a patient has to take 9 months course of anti-tuberculosis drug. Definitely he is going to have some peripheral neuritis. Okay, so when we give this vitamin B6 along with the drug. Idea is this drug should not cause PLP deficiency. Penicillamine with PLP causes thiazolidine derivatives, and same thing happens like this isoniazide. Now, if there is any deficiency of PLP, there will be synthesis of coenzyme, niacin coenzyme, NAD, NADH, NAD, NADP will decrease. Xanthuronic acid excretion in urine will be increased, and this is estimated after tryptophan load test. a tryptophan amino acid is given a good quantity, and in his urine that xanthuronic acid, whether his excretion is increased or not, that will be seen. In case of PLP deficiency, this will increase. If it doesn't increase, means there is no PLP deficiency. Then assay of erythrocyte transaminase is more sensitive test nowadays. So manifestations are convulsion due to decreased GABA, sphingolipid synthesis, decreased demyelination of the nerve, and which will cause also peripheral neuritis. Pellagra, we have seen pellagra is a disease of niacin deficiency. So here from tryptophan there is deficient niacin synthesis because of the PLP deficiency. So signs and symptoms of pellagra will be there in vitamin B6 deficiency also. Then irregular indentations of the nails will be there. Nails will be ridge-like. Hypochromic microcytic anemia will be there due to decreased heme synthesis. Then it is Pyridoxine-Responsive. See, anemia is there. Frequently what we do, if there is anemia, we give iron tablet. This type of anemia, it is refractory to iron therapy. Here we have to give pyridoxine. Pyridoxine we have to give so that heme synthesis is normalized. This is called sideroblastic anemia. This is iron refractory anemia. Neurological manifestation like depression, irritability, nervousness, mental confusion because of the decreased serotonin synthesis. There will be dermatological manifestations, then hematological manifestation as stated above. Okay. Toxicity, only water soluble vitamin is significant toxicity. Excess use of vitamin B6 may cause sensory neuropathy. When it is used more than 200 mg per day, there may be neurological damage. So excessive intake is not good for. So this is a case study. Case study, get the snap of this. Case study you will get in your practical also, in your theory examination also. So these are the questions we have already explained. You also prepare the questions, answer of the questions. Okay. Coming to the next vitamin, folic acid. So in water soluble vitamin we have two groups, energy releasing and hemopoietic. So folic acid is a hemopoietic vitamin. It is required for RBC maturation. Known as folacin also and vitamin B9 also, abundantly present in green leafy vegetables. It consists of three components: pyridine ring, para-aminobenzoic acid and glutamic acid. Para-aminobenzoic acid is attached with glutamic acid is attached with para-aminobenzoic acid by peptide bond. What is peptide bond? You have known, no? Protein. In protein, this chemistry, madam has told you peptide bond. Okay. So through peptide bond, it is attached to para-aminobenzoic acid. Folic acid mostly has one glutamic acid, and it is called monoglutamate. Active form of folic acid is tetrahydrofolate synthesized by dihydrofolate reductase with the help of 2 moles of NADPase. NADPase provides reducing equivalence. So in case of NADPase, in niacin metabolism we have mentioned some reactions where synthetic activity of NADPase is there. So this is one of the reactions where NADPase is used for synthesis of tetrahydrofolate. Absorbed as monoglutamate from the food. Dietary polyglutamate is hydrolyzed by folate conjugate. In the diet, it is present as polyglutamate. So polyglutamate is not absorbed. Polyglutamate is cleaved by the folate conjugate to monoglutamate after removing 6 or 7 numbers of glutamic acid residue. So it becomes monoglutamate. Only then it is absorbed. Now, folic acid, it has 3 components I told you. Pteridine ring, para-aminobenzoic acid, with the help of peptide linkage, the glutamic acid is attached with this. Now these two, pteridine and para-aminobenzoic acid, is called teichoic acid. And when with teichoic acid, glutamic acid is attached, this is called teroyl glutamic acid or folic acid. Human being cannot synthesize para-aminobenzoic acid, or it cannot attach glutamic acid residue to the teichoic acid. So that's why this folic acid also has to be supplied in the body from diet. Dietary sources are spinach, broccoli, avocado, citrus fruit, kidney, then lima beans, eggs, beef liver. Fortified foods nowadays, flours and ready-to-eat breakfast cereals, they are fortified with monoglutamic type of folic acid. RDA for adult, it is 200 microgram per day and needs to increase in pregnancy and lactation. When therapeutic dose is given 1 milligram per day, but actually it is given more than 5 milligram per day. Okay, sometimes 5 milligram, sometimes 10 milligram. There is a reason why it is given like that. Then absorption of folic acid, it may not be important for exam, but as folate monoglutamate, it is absorbed in the cell and it is stored as, it is converted by dilute to folate reductase to folate reductase, then in tissue and it is converted into N5-methyl tetrahydrofolate. N5-methyl tetrahydrofolate then stored in this tissue as polyl polyglutamate by the enzyme polyglutamate synthase. Now, this folic acid is very important for 1-carbon metabolism. 1-carbon metabolism means transfer of carbon from one compound to the another compound. Okay. So these are the 1-carbon compound, N-formyl tetrahydrofolate, N5, N10 methyl tetrahydrofolate, methinyl tetrahydrofolate, methyl tetrahydrofolate. Out of these 3 can be, 3 are interconvertible, but methyl tetrahydrofolate cannot be converted into other 3. That's why in vitamin deficiency, when there is deficiency of vitamin B12, the homocysteine cannot be converted to methionine. So methyl group from the tetrahydrofolate cannot be removed, because in this reaction methyl group is shifted to the received by the homocysteine and converted into methionine. So there will be a stagnation of N5-methyl tetrahydrofolate. This will increase in the blood. Okay. Now, but as it is, this reaction is reversible. It cannot synthesize. Methylene tetrahydrofolate cannot be synthesized from this. So it gets accumulated in the body, tetrahydrofolate. So see, folic acid is there as tetrahydrofolate, but it is in conjugation with the methyl group. The N5-methyl tetrahydrofolate cannot release methyl group, so it is accumulated in the body. That is called functional folate trap. When you estimate the folic acid in body, you will find it is normal, but it's not available for activity because it is already stagnated there as methyl tetrahydrofolate. And if methyl group is not removed from the tetrahydrofolate, it cannot take part in new reaction. Here, homocysteine is converted to methionine with the help of homocysteine methyl transferase or methionine synthase. But when there is, now here what happens, that methyl group is donated by the methyl cobalamin and it becomes cobalamin. Now N5 methyl tetrahydrofolate, it gives the methyl group to the cobalamin and again methyl cobalamin is formed. The methyl tetrahydrofolate becomes again tetrahydrofolate. Now it is free to take a fresh reaction, undertake a fresh reaction. Okay. Now in case of vitamin B12 deficiency, this methyl group cannot be transferred to homocysteine, so it gets accumulated, and that is called folate trap. Folate is trapped in the form of N5 methyl tetrahydrofolate. Folate trap, short note, or explain why. One question you will get. Now in case of methionine, what happens? It is activated. Methionine, even though it is containing this methyl group, it cannot donate methyl group because it is not activated form. So it is activated by the methionine adenosyl transferase to S-adenosyl methionine. Active form of methionine is S-adenosyl methionine, SAM. Okay. Now it will donate methyl group to the acceptor group. Acceptor group means there are bioamines synthesis, so they will need methylation. So this methylation is done with the help of the S-adenosyl methionine, and the S-adenosyl methionine becomes S-adenosyl homocysteine. Now in S-adenosyl homocysteine will be cleaved by the adenosyl homocysteinase. Adenosine will be removed and homocysteine will be again released alone. Now this homocysteine, with the help of methyl cobalamin, will get converted into methionine, and this reaction will help regeneration of tetrahydrofolate. By this way, it is the cycle is made active, and if there is vitamin B12 deficiency, there will be folate trap. Folate deficiency causes malnutrition, elderly patient, alcohol intake, then absorption, problem in absorption like intestinal disorders through celiac disease, gluten-induced enteropathy, resection of the jejunum, then increased demand like pregnancy, lactation, chronic hemolytic anemia. Then in drug therapy like phenytoin, hydantoin, anticonvulsant and sulfasalazine. These will cause folate deficiency. These drugs are structurally nearing that folic acid structure, so they inhibit the synthesis of folic acid. Consequences of folate deficiency: DNA damage, deranged DNA synthesis, there is macrocytic anemia with megaloblastic change, neural tube defect in case of early pregnancy, then hyperhomocysteinemia that causes coronary artery disease, then cerebrovascular accident. These are the result of hyperhomocysteinemia. Now, macrocytic anemia, what is the reason? Due to folate deficiency, there is deficiency of N5, N10 methylene tetrahydrofolate. This is another 1 carbon transporter. So there is decreased synthesis of thymidylate. Now this decreased thymidylate synthesis will stop cell proliferation in S phase of rapidly proliferating cell in the hemopoietic cell. So this defect in DNA synthesis, there is a dissociation between maturity of nucleus and cytoplasm. Okay, so cytoplasm remains bigger than the nucleus, and that is the reason why macrocyte is formed, and there is a megaloblastic change. In case of anemia due to folic acid deficiency, there will be macrocytosis, that is increased size of RBC, then hypersegmental neutrophils will be there. In bone marrow, immature large RBC precursor cells or megaloblasts will be there. Then clinical picture of anemia will be there. Splenomegaly will be there because the RBCs are not matured properly, so they will be destroyed by the spleen. So due to overactivity of this spleen, it becomes bigger. So there will be splenomegaly. Splenomegaly means big spleen. Pale yellow appearance of the patient, it is because of the high bilirubin. Because of the abnormal RBC, they will get lyse. So the heme portion is excreted. Excretion of heme portion will be increased, and there will be increased bilirubin. As because this is hemolytic anemia, there will be increase of unconjugated bilirubin. That you will know after a few days what is unconjugated bilirubin. Clinical manifestations in history, we can get alcohol intake, poor nutrition, and use of drugs. When you take the history of patient, you may get history suggestive of this condition. The alcohol intake, poor nutrition, use of drug. Then there will be oral lesions, soreness in the tongue, red and swollen tongue, angular stomatitis. Then GI symptoms will be there: nausea, vomiting, abdominal pain, and diarrhea because of the anemia. Hyperpigmentation, dorsal surface of the finger and toes, there will be abnormal pigmentation. Now, difference, how we differ in deficiency, anemia due to folic acid deficiency and anemia due to vitamin deficiency. We have to differentiate. So, in case of folic acid deficiency, there will be normal B12. In case of vitamin B12 deficiency, there will be low B12. So, folic acid deficiency, we estimate vitamin B12. If it is normal, then deficiency of folic acid is there. Normal methylmalonic acid in case of folic acid deficiency, and elevated methylmalonic acid in case of vitamin B12 deficiency. There is a reaction where which is catalyzed by that reaction is helped by the vitamin B12. So in case of deficiency of vitamin B12, there will be increased methylmalonic acid. In this reaction, methylmalonic acid is converted into succinyl CoA. So once this is blocked, methylmalonic acid will remain high. Then in case of folic acid deficiency, there will be elevated homocysteine. Why homocysteine will remain elevated? We have already explained. But in case of vitamin B12 deficiency also, there will be elevated homocysteine level. In case of folic acid deficiency, tetrahydrofolate is not available in enough, so there will be less conversion of homocysteine to the methionine. So this is the reason for increase. In case of vitamin B12, the N-methyl tetrahydrofolate is trapped, so there will be increased homocysteine level. Hyperhomocysteinemia and coronary artery disease. Decrease the activity of lysyl oxidase, interact with lysyl residue of the collagen, interfere with collagen cross-linking, leads to the abnormality of the collagen in the vessel wall. These are the reasons for where the homocysteine interferes the normal work. Then homocysteine forms homocysteine thiolactone. This is a free radical which thiolates LDL particle and helps in formation of atherosclerosis due to aggregation of the this molecule in the by the cells of the endothelial cells of the vessel. Neural tube defect, there may be spina bifida, here will be a gap and a sac-like thing will come out. Sac-like thing will come out, so this is called spina bifida. And anencephaly, the brain portion, this portion is grown well, but in the brain portion is not there, so it will be gap. Encephalocele, in the back side of the head, there is a seal, there is a bag-like thing. So that is called an encephalocele. Due to the deficiency of vitamin folic acid, there is a neural stem cell proliferation is hampered, and that causes these problems. So in that case, what we do, once there is diagnosis of pregnancy, we give folic acid supplement to prevent neural tube defect. So you will get a question in early pregnancy, folic acid supplementation is given. Explain why. This is the reason. So prepare it nicely, definitely you will get question. Folic acid deficiency laboratory findings. The normal folic acid level is 3 to 16 nanogram per ml, and erythrocyte is more. So blood folic acid will be less in case of deficiency. There will be increased bilirubin due to that hemolysis. Then there will be LDH level will be increased, homocysteine level will be increased, and histidine load test. When histidine is given, it cannot be converted into methinyl tetrahydrofolate. So there will be increased formiminoglutamate acid that is excreted in the urine. So this is estimated, and indirectly the folic acid deficiency is diagnosed. But nowadays it is not performed. Management, folic acid 1 to 5 milligram. Then if there is intolerance to folic acid, IV, subcutaneous or IM formulations can be given. In concomitant vitamin B12 deficiency, both folic acid and vitamin B12 is given. Diets are advised accordingly. In case of untreated folic acid deficiency, consequences are megaloblastic anemia, pancytopenia, glossitis, angular stomatitis, oral ulcer, neuropsychiatric psychiatric manifestations, depression, irritability, insomnia. These will be the symptoms of folic acid deficiency. High amount of folic acid intake may increase the risk of colon cancer or prostate cancer. So excessive amount should not be given. So these things are the sulfonamide, methotrexate. These are the folic acid analogs, and they inhibit this incorporation. They are abnormally incorporated in the pyridine ring, and thereby folic acid synthesis is hampered or stopped. So this is given as antibacterial. So if bacteria cannot synthesize folic acid, and their DNA or RNA is not synthesized and they die. Methotrexate is an anti-cancer drug. It inhibits dihydrofolate reductase, so there will not be tetrahydrofolate for fast growing cells and there is death of the cancer cells. Pyrimethamine, it is an anti-malarial drug. Same way it acts, inhibitor of the folic acid synthesis, and the malaria parasites, they die of this lack of folic acid. Now next is vitamin B12, Cobalamin. Cobalamin, we can remember its biochemistry in this way: C-O-B-A-M-I-N-E, Cobalamin, MMS, Megascan. Just to remember mnemonics. It has choline ring, it has cobalt in its choline ring, then active form is adenosyl cobalamin and methyl cobalamin. Intrinsic factor is required for its absorption. Then neurological symptoms due to its deficiency. It is also called extrinsic factor of Castle. MMM is the reaction which it catalyzes, which the enzyme of the reaction where vitamin B12 is required. It is the methyl malonyl CoA synthase, methyl malonyl CoA synthase, and MS means methionine synthase. Mega means megaloblastic anemia. SCAM means subacute combined degeneration due to deficiency of vitamin B12, and methyl malonate in urine in deficient state. Presence of methyl malonate in the urine in deficient state. So it is just to remember the thing so that we can explain later on. So cobalamin, it has a choline ring in the center of the 4 choline rings, and in the center of the 4 nitrogen atom there is a cobalt molecule. So tetrapyrrole ring, central cobalt atom, 4 nitrogen atoms of choline ring are related with each other by 4 coordination bond. 5th bond is attached, this is the 5th bond attached with nucleotide side chain dimethyl benzimidazole. This is the dimethyl benzimidazole. Diethyl benzimidazole. Then 6th bond is with the functional group. When cyanide is there, it is called cyanocobalamin. When methyl is there here, it is called methyl cobalamin. When hydroxyl group is there, then it is called hydroxycobalamin. And when deoxyadenosyl is there here, functional group, it is called deoxyadenosyl methionine. Deoxyadenosyl cobalamin. Vitamin B12 is synthesized only by the microorganism and not by the animal and plant. So, source is only animal origin. These are the 4 forms of vitamin B12. Cyanocobalamin is usually commercial preparation, and this hydroxyl, it is intracellular intermediate form, and sometimes injectable forms are given as hydroxyl cobalamin, and coenzyme form is methyl cobalamin and deoxyadenosyl cobalamin. Sources: liver, egg, milk, oyster, chicken, pork. Then fortified foods are also available. Human gets small amount of vitamin B12 from their intestinal flora. Body stores 4 to 5 milligram, which is enough for 3 to 5 years. So vitamin B12 deficiency radially doesn't occur. Doses: in case of adult, it is 1 to 2 microgram per day. and pregnancy 2 to 6, 2.6 microgram, lactation 2.8 microgram, and in case of therapeutic dose, it is given as 1 milligram per day oral. Vitamin B12, what happens when we take, it binds with R binder, which is also called cobalamin or heptocorin. It is synthesized by the salivary gland. Then it comes to the stomach, and in the stomach, the intrinsic factor is secreted by the parietal cells, and secretion of gastric parietal cell intrinsic factor is stimulated by the mechanism which also stimulates secretion of gastric acid by the histamine, by acetylcholine, by the gastrin. So this vitamin B12, when it comes to the stomach, the vitamin B12 is released from this cobalamin, and this vitamin B12 intrinsic factor, they enter in the intestine, and there the vitamin B12 binds with intrinsic factor. Intrinsic factor is very much essential for absorption of the vitamin B12. Now, when vitamin B12 is absorbed in the cell, inside the cell, it gets dissociated from the intrinsic factor, and it is converted into methylcobalamin. And there it binds with the transcobalamin. This transcobalamin, it brings the vitamin B12 to the cell basal layer of the basal area of the cell, and from there again it dissociates from the intracellular transcobalamin. It passes to the portal vein. Here again it binds with the transcobalamin 2. From there, it is some of the vitamins they are carried to the liver, some of the vitamin B12 they are carried to the tissue where it is to be used. In the cell, the vitamin B12 is released from the transcobalamin 2, and it is converted into deoxyadenosyl cobalamin, and it is stored in the liver. And so also in the cell, it is released from the transcobalamin, and it is used when it is necessary in the cell. Vitamin B12 metabolic function, it functions as methylcobalamin used by the enzyme methionine synthase. We have seen from homocysteine to methionine synthesis. Homocysteine to methionine synthesis. And this vitamin B12, it passes to the mitochondria, converted into adenosyl cobalamin, and it helps the reaction of methyl malonyl CoA mutase, where methyl malonyl CoA is converted into succinyl CoA. So, when there is deficiency of vitamin B12, there is increased homocysteine and there is increased methyl malonyl CoA. Biochemical functions: hematopoiesis, DNA RNA production, methionine and choline synthesis, then myelin sheath formation, regeneration of folic acid. Here is the regeneration of folic acid that as tetrahydrofolate. We have explained this earlier. This is also has been explained. Now, in case of chain fatty acid and chain fatty acid metabolism, then metabolism of valine, isoleucine, methionine and threonine, the propionyl CoA, 3-carbon compound propionyl CoA is formed. Now, propionyl CoA is converted into methyl malonyl CoA by the enzyme propionyl CoA carboxylase. And this methyl malonyl CoA is by the apomerase is converted into L-methyl malonyl CoA, and here it is converted again by the methyl malonyl CoA mutase to succinyl CoA for further metabolism through TCA cycle. But the vitamin which function here as deoxyadenosine cobalamin. So when there is a deficiency of vitamin B12, this L-methyl malonyl CoA will increase and will be excreted in the urine. So we estimate this methyl malonyl CoA in case of vitamin B12 deficiency. These are very important reactions. This will be asked. And the condition where methyl malonyl acid is excreted in the urine is called methyl malonic aciduria. Deficiency causes are gastric disorder like achlorhydria, pernicious anemia, gastrectomy, gastric atrophy. Pernicious anemia, it is very important. There is intrinsic factor deficiency in pernicious anemia. It is the autoimmune disease. The antibodies against the parietal cells of the stomach. So when there is antibody formation against the parietal cells of the stomach, there is destruction of parietal cells. And parietal cells, they are responsible for synthesis of that intrinsic factor. So in pernicious anemia, there is deficient absorption of vitamin B12, and that causes the megaloblastic anemia. Intestinal disorder like iliac resection, screw, tuberculosis, pancreatic disease. Then drugs like metformin, colchicine decreases absorption of vitamin B12. So when metformin is an anti-diabetic drug, when you give for long, hello, hey, what you are talking? You don't require this? Both of you, I am seeing you are talking for a long time. Don't disturb, okay? If you don't require, no problem, but don't disturb me. Fish tapeworm. This is one of the important cause of vitamin B12 deficiency. Fish tapeworm, when infested in human being, they consume vitamin B12. That causes, even though the person is taking vitamin B12, then still there is deficiency due to the utilization of vitamin B12 by the fish tapeworm. Folic tract, hyperhomocysteinemia, and subunit bacteria combined degeneration. These are the deficiency manifestations. These are because of the demyelination and abnormal fatty acid synthesis. Nail changes, there is ridge-like changes in the nail, and in megaloblastic anemia, what have been explained in folic tract and folic acid deficiency, the same cause is there. Symptoms of anemia: fatigue, weakness, palpitation, then sore, beefy red tongue, weight loss, diarrhea will be there. Neurological symptoms: numbness, paresthesia, ataxia, abnormal reflexes, diminished vibratory sensation. Numbness means the patient will feel as if his limbs are weak. Paresthesia means he will feel that something is creeping in his skin. Okay, ataxia means he will have difficulty in walking. Abnormal reflexes, there you will find in physiology what is reflex. Reflex will be abnormal. It is not elicited as it should have been. So this is the already we have described the thing, cyanocobalamin from homocysteine, how methionine is synthesized, then why this DNA synthesis, how it is causing the problem in DNA synthesis, Hamidylate synthesis is hampered, so there is abnormal DNA synthesis. Demyelination of neurons, decrease and defective fatty acid synthesis in myelin sheath, cerebral cortex and spinal cord. There will be both sensory and motor neuron motor sensation defect. That's why it is called combined, subacute combined degeneration. Methylation, here what we told, adenosyl methionine, it will supply methyl group to the acceptor molecule. Here are the acceptor molecules. Say how it is transferred when there is synthesis of biogenic amines. Then in protein some degree of methylation is required. It is then phospholipids, neurotransmitters synthesis, that methylation occurs. So this will be hampered. This is the methyl malonyl-CoA. In vitamin deficiency, vitamin B12 deficiency, there will be increased methyl malonyl-CoA. There will be deficient propionyl-CoA metabolism. Then incorporation of methyl malonyl-CoA in fatty acid synthesis, which will cause abnormal branches in fatty acid formation that disrupt neuronal membrane structure. That is the cause why subacute combined degeneration occurs. Vitamin B12 deficiency, assessment is done by estimation of vitamin B12. This is the normal level of vitamin B12. Then peripheral smear indirectly, we will find macrocytic hyperchromic anemia will be there. Bone marrow will show hyperplasia. Schilling test is not done nowadays. Here radioactive vitamin B12 is given to see the status of body vitamin B12. Now it is not done. Then in pernicious anemia, detection of intrinsic factor. Pernicious anemia, we find how much intrinsic factor is there. If it is absent, then we diagnose as pernicious anemia. Then as there is increased hemolysis, there will be increased bilirubin. The jaundice will go up high. Then homocysteine level will be high due to the failure to conversion to methionine. And methyl malonic acid will increase in urine and plasma. So we have discussed this one. So vitamin C we will discuss in next class. So up to that, we will finish here. Read it. All these folic acid and vitamin B12, these are very important. Okay, thank you.